Nice to be invited here among esteemed colleagues and lots of friends in the room. So without wasting time, let's crack on. So I'm going to talk about a rational approach to hypoxic respiratory failure. I'm not that old to give an overview of everything that's happened, but I've made enough mistakes to have learned over the years that I can try and rationalize a few things as we've gone on. And for me, management of respiratory failure starts here. You have to have a diagnosis. For me, there are three tenets of intensive care. You diagnose, resuscitate, treat, support the organs, and do no harm. And if you crack those three, we pretty much crack intensive care. So this is the first tenet. We have to have a diagnosis. Bilateral infiltrates. This could be Legionella. It could be pneumococcal that's gone bad. It could be H1N1. This could be any bacterial infection. This could be this was a sigmoid perf who aspirated on the ward and then came to intensive care. And this was an aplastic anemia who developed Charlie after some weeks of this treatment. And all these X-rays can be interposed with each other in terms of differential diagnosis. And ventilation is not a treatment. We have to get an underlying diagnosis. And it could be one of many, many things. I love this slide, it's psychedelic. It's just too colorful for X-rays and things. And we have to have a diagnosis. You have to know. So the first H1N1 I treated when I was working in Cardiff was we had him on intensive care for about 4 days as a pneumococcal pneumonia, and he was a sentinel case with H1N1 around the 2008-2009 period. So you have to have a diagnosis. We have to have a diagnosis. We have to be able to treat it to get a positive outcome. And it almost begins and ends there. I have a few more slides than that, but that's absolutely fundamental. Next bit is the ventilatory management, and over the years, the old textbooks still talk about adequate tidal volume. You correct PCO2 to normal. You have a normal PO2, and you sacrifice FiO2. You give as much FiO2 as you want. And this was a case that was discussed in the New England Journal about a decade ago, when they ventilated this young girl who had a amniotic fluid emboli. With large tidal volumes to aim for normal pH, normal PCO2, and normal FiO2. And this was the tragic consequence of a lung having been ventilated that badly. Around that time evolved, or even up to a decade before that, evolved the concept of ventilator-induced lung injury. And that's the lung injury that we cause by ventilating patients. And there are a couple of, this polytrauma, barotrauma, atelectrauma, and biotrauma. And Professor Slutsky very nicely combined the hypothesis into one group to say it's a biochemical injury, it's a biomechanical injury. There's lots of release of cytokines from the lungs that drives inflammation elsewhere, and then results in multi-organ failure and death. So that's where the whole premise of ventilator-induced lung injury comes, and how do you protect the lung? And essentially what you do is you're exploiting the lung hysteresis. And the simplest way of explaining lung hysteresis is blowing a balloon. Yeah. Put a lot of effort in, take some time, blow up, leave it off, stays off, and then suddenly comes down. And that's what we're trying to achieve here, is preventing atelectasis, preventing polytrauma. You sort of recruit the lung up and stay somewhere up here. It's as easy as that. Probably not. And the whole strategy, the thought process started in the early 90s, and you had this really beautiful paper by Professor Amato looking at low tidal volumes versus conventional, and massive survival difference in the two groups. I mean, albeit there's a small study, a single center study in the high mortality in the control group, but still the first big paper to start detailing the impact of ventilation on mortality. And then we're all familiar with the ARDSNet trial, 6 ml versus 12, plateau pressures versus high plateau pressures, and significantly lower mortality. But for me, the biggest thing here is that what the paper shows, that you can save 9% in terms of absolute mortality if you ventilate our patients gently. That's what it tells me. 6 ml per kg tidal volume, ventilate them gently. There are lots of other things that go on. There's a high PEEP strategy behind it, but just getting that part right, you can make such a profound difference. And then there's the next question, how low should we go? Is 6 ml enough? 5, 4, 3, 2, oscillate. It's slightly in the limbo, but this is another very nice paper which shows even at small tidal volumes, you have quite a lot of over distension. If you were to drop the tidal volumes even further, you drop off the volutrauma. There's less cytokine release. So there is a hypothesis that if you can drop your patient's tidal volumes below 6 ml without compromising the cardiac hemodynamics, is good. And there's a further paper by the same group looking at extracorporeal CO2 removal, and they drop the tidal volumes even further with good outcomes. And I think the two big trials, the European trial and the UK trial, looking at extracorporeal CO2 and its impact on survival. And you have volutrauma, atelic trauma, and again, you're up here below the lower inflection point, recruit the lung improves, and you want to ventilate gently the downslope of pressure volume curve. And again, very elegant trials looking at high PEEP versus standard PEEP as defined by the ARDSNet, improved outcomes. But what I want you to focus all along is the tidal volumes they've been using, small tidal volumes. And there's a meta-analysis that came up later on to say it's useful to have high PEEP strategy in patients with severe or refractory hypoxic respiratory failure. High PEEP strategy in mild ARDS is probably more harmful. So if you want to use high PEEP, 15, 18, 20 of PEEP, you're looking at the severe end of ARDS. And to cliche it, history has a habit of repeating itself. This was an observation in 1890 that says too much oxygen is bad. And we're still trying to prove it or disprove it, depends which way you look at it. We have the paper in JAMA looking at stroke patients getting too much oxygen, patients MIs getting too much oxygen, poor outcomes. 1890. We take a long time to learn. Or we probably never learn. And again, it causes free oxygen radical related problems, atelectasis, mitochondrial dysfunction. And there are new trials, I think led by the Dutch group, looking at what is the optimum saturation that we should be aiming for. And what about rescue therapies? This trial looking at atracurium versus as an infusion versus atracurium as and when needed. Again, big survival difference between atracurium versus no PRN. Again, both groups at low tidal volumes. Big survival difference, less number of days on the ventilator, less organ failure. And this atracurium stuff is interesting. It almost reminds me of an orthopedic teaching me intensive care. Yeah, and I think there is something to learn from the orthopedic surgeons. Not the empathy part of it, but the fact, that when you fracture your arm, for example, what they do is take an X-ray, they reduce it, put it in a cast, and leave it to heal. And when the cast is set, after 4 weeks, 6 weeks, then they start flogging you. They don't take an X-ray every other day and sort of move your arm and, oh, is it hurting? Oh, I'm sorry, I'll put it back again. Yeah, it's you rest the limb, and when it is done, you exercise it. In ventilation, every shift, I do better than my other colleagues. I come and play with the ventilator. I know better, so overnight something changes. Back in the morning it goes wrong. And when I really want to do the sedation break and get them mobilizing, we don't do it. Yeah, a bit of humility. Orthopedics can teach us something. I don't have any private practice. I don't work with the orthopedics, but there's still something to learn from that. And this is kind of the a very simplistic way you'd use more cystatracurium as an infusion in severe ARDS. It's not advisable. If you had mild ARDS, you'd rather have the patients breathing spontaneously, and there's no clear-cut advice as to what you do in moderate ARDS. High frequency oscillator is something very close to me. We did the Oscar trial. No difference in outcomes. The mortality was 41% for both control and HFO. And in our study, the tidal volume was 8. It's a very expensive way of conducting an audit of tidal volume practice in the UK. Yeah, 8 ml per kg. And when we all swore when we started off the trial that we would abide by the ARDSNet and we'll do 6 ml per kg. So that big difference in practice and perception. And on the same time, the Oscillate group produced their paper. They also had 41% mortality in the HFOB group, but the conventional group had 29% mortality, and they did 6.1 ml per kg tidal volume. So again, all these papers show, your sort of fundamental principle is, ventilate the lungs gently. Back to proning. Again, the Guerin paper, very elegant, shows that in severe ARDS in a highly selected subgroup of patients, it's also useful to review the consort diagrams when you're reading a paper. I think they excluded about 95% of the patients screened. It's a highly selected, but in that group, fantastic outcomes, enviable outcomes. And I think one of the reasons why, of course, there's a lot of science behind proning, but one of the things I like about proning is that no medic ever goes in place with a ventilator when the patient is prone. I've never gone and done a sedation break. I've never done a recruitment maneuver. I've never manipulated PEEP when a patient is prone. Again, the ventilator-induced lung injury is not just the ventilator. It could also be called as the physician-induced lung injury. The Cesar trial, very elegant, a lot of hard work into it. But for me, the big learning from Cesar was that the cardiothoracic surgeons achieved better outcomes than the intensivists. Yeah, so the patients who did not receive ECMO in the ECMO centers did better than the patients who were treated by intensivists in other hospitals. Again, standardizing treatment, regionalizing therapy is probably something that we need to, as a group, need to reflect on. I also started to believe that improvement in ARDS and rationalizing ventilation is not just about ventilators. The FACT protocol, conservative fluid strategy versus liberal fluid strategy, produces a significantly better outcome, less ventilator days. So there is a slight caveat. There's a very nice review by Professor Gatineau in one of the recent current opinions. He talks about the conservative strategy 1 year down the line. Is there more neurocognitive impairment in these patients? And that's something we need to start exploring. I'm quite, I'm not sort of angry with our profession, but I think we as a professional group, we need to change. We are like plumbers. When the patient is in our ICU, it's a closed ICU. Once the patient leaves us, we've got nothing to do with them. So the impact of dehydrating the patients, the impact of sedation, the impact of ventilation is only pertinent to us as long as they're on the ICU and blocking our beds. Once they're outside the ICU, it's no longer our problem. We really need to have more follow-ups of our patients and try and tease out how much impact we are having on them. Again, the physician-induced injury. Early mobilization. Almost every metrics in terms of neurocognitive, physical function gets better if you get the patient sitting out. Among my biggest challenge over the last 3 years has been to engage with my physiotherapist to move from doing physio to achieving rehab. And I failed, I continue to fail. I will succeed one day, but I'm failing. But that's what the trials say. You have to get them mobile. You have to do your sedation breaks. I've got confused with the steroid saga. It goes on and on and on. Every decade produces a new paper, the new thought process. And I'm confused, and I won't confuse you anymore. I don't use steroids in my practice. Then there's the statin in massaging the endothelium, and that didn't show any difference between placebo and statin. And there are lots of similar drugs. There's the beta-2 agonist, there is the APC, there's a whole litany of drugs that we've tried to use to reduce ARDS, and it hasn't worked. On that depressing note, has the mortality changed? There has been a trend towards reduction in mortality. This is a decade-old paper, but there's a big drop up here from here. Any reason why that the big drop took place there? They had a new definition to change the goalpost. That was the old consensus definition, came out in around 92, 93. And there is a further analysis which still shows the ICU mortality, hospital mortality, and 28-day mortality still remains frighteningly high. There's also a big variation in what we do. So just as a show of hand, how many of us use 6 ml per kg tidal volume? Yeah, perfect. Thank you. That's what the trial says as well. 80% of us said we did 6 ml per kg tidal volume. And when they send the medical students to look at the charts, the medical students didn't know what 6 ml was. They just took the charts, divided it, and moved on. Yeah. 10 ml per kg was the ideal for the consistent tidal volume we used. The same thing with sedation. So it's not just ventilation. So 65% in the study said they did a daily interruption, 25%, just 25% did the delirium screening. And when the junior doctors or the medical students went around, they found the sedation, the practice was half of what we said. Big difference in practice and perception. And it goes on and on and on. You know, this is the impact of education. This is a Spanish study on impact of sepsis campaign. Before, the compliance with the bundle was 5%. It improved to 10%, and when they took the education away, it dropped back to 5%. And there's no change in mortality. So we invest a huge amount of money in the education programs. So we have to do something different. Or at least I have to do something different in my practice. And there are 3 things I'd like to discuss. One is, it's an abnormal physiological state. Why accept normal physiology? It's about time to change our language of how we describe respiratory failure. Permissive hypercapnia is like an inconvenience, whereas should we change it to therapeutic hypercapnia? The Amato trial, the ARTSNet trial, the survival was highest in the group that has low tidal volumes and high CO2 and low pH. Why do we still aim for normal pH and normal CO2s? We aim for normal oxygenation. Should we look for permissive hypoxia? So this is, apart from the 6 ml thing, this is the other thing I get from the paper, is that should we be oxygenating by tidal volume? It's a crazy concept. But in the group that had 6 ml per kg, they were more hypoxic, up to 7 days. But as time goes on, the hypoxia improves. It matches the 12 ml. And we know the 6 ml did better. So though they were hypoxic to start with, the outcomes are better. So why aim for normal oxygenation? And we know from all the trials that we've done over the years, whether it be oscillation, whether it be ECMO, whether it be nitric oxide, improvement in oxygenation doesn't improve outcomes. So we really need to recalibrate how we think, how we practice, how we teach. Do you know this gentleman? Yeah, so I was going to say, those who know don't say, but that doesn't make sense either. Yeah, it says David, Sir David Placeway. And I like his philosophy in that principle of marginal gain. Yeah, I love to say this in public. I think I should record it as well. My wife is right. When I go to lose weight, I go with all gusto, and I'm going to lose in 1 month, I'm going to get everything done. Forget the diet, forget everything. But the sensible approach would be just keep 1% improvement in 10 different things. You're more likely to succeed. And we've got lots of things that we can make that 1% improvement. I don't want a 10% improvement in everything. We've got low tidal volume, we've got PEEP stratification, we've got fluid management, we've got early mobilization. We can spend more time doing sedation breaks, spontaneous breathing, the VAP bundles, because enough there to make a difference. But we say, no, I'm going to tackle just one thing at a time. So is there any evidence that it works? This aggregated, it works in cycling. Does it work on intensive care? So I'm trying to extrapolate this data. This is a really, really nice paper from the American Journal. And what they did is they looked at the incidence of ARDS over 8 years. It's a tertiary referral hospital, the surrounding hospital, the rural hospitals. So everything came to that center. So they had a pretty good understanding of what ARDS was. They divided ARDS into primary ARDS, that is community acquired, and secondary ARDS, that is hospital acquired. And they found that over the years, the age profile remained the same. Over the years, there were sicker patients getting admitted to intensive care with ARDS, But over the years, the mortality started coming down, both ICU mortality and hospital mortality. So with admitting sicker patients, and odds mortality was getting better. And they looked at the trends. So this is community-acquired ARDS. The trend remained much the same, but for hospital-acquired ARDS, it dropped significantly over 8 years. And when they teased the data out, they found that over the 8-year period, what they had changed was all these things: the transfusion practice, the leukocyte depleted, mechanical ventilation got better, they had the sepsis bundles coming in, they had better VAC prevention, they had a full-time intensivist working, they had outreach team, medical records. So if we said an outreach team is going to make a difference to ARDS, we'd all laugh about it. But if we have the whole package together, make a small stepwise improvement, as you see up here, you can make a big difference in ARDS. Anyone recognize this gentleman? I think we're going to hear more and more. We actually hear about him almost on a daily basis, but we don't really think about it. We're not even nudged in that direction. He's Richard Taylor, and he's the author of the book on the nudge concept. You know, how you make, the concept is around behavioral economics, but it's around how do you make things simple so it becomes user-friendly, and how do you get constant feedback. So among the most easy thing that we have now are the apps on our mobile phones. Yep, we can access the bank on it. Fantastically easy. And every time we use it, it asks for a feedback. How did we do? If you have a Mac, it has a small smiley face on the top right. How did I do? And when we look at our electricity bills, it's coming in. When we look at our pensions, it's coming in. So he's nudging us. They said the number 10 Downing Street has a nudge unit, which sort of thinks about how can we simplify processes to make a difference. So we tried to apply some of this principle on intensive care. So this is a colleague's work, called Chris Bordeaux and Tim spent a lot of time working on this, and this is the work that they to show. This was before the last paper on HES or starch came out, which is harmful. So for 10 years before that, we had a lot of education program. Yeah, the whole team, and this is not good, and the journal clubs and everything. And what Chris and Tim and a colleague called Jeremy Bewley designed was we have a CIS system, so they did two things. The first thing was that they kept the starch a foot away from the door. Yeah? And the second thing on the CIS, you had to put one extra click to move from a prescription of crystalloids to colloids. You're still allowed to use whatever you wanted to use. All that you had to do was click one extra button on a computer screen to prescribe colloids, and take one extra step in the resource room to get the colloids out. And that's the difference in consumption. Yeah? So we thought, let's apply this to ventilation. So among the most difficult thing I find cognitively is calculating tidal volume. So I have to calculate height, I have to measure height, so I have to go find an IKEA tape. Yeah? How many of you use IKEA tapes for height measurements? Shamelessly. Yeah? IKEA tapes, measure the height, then write it down somewhere on the chart. Every breath the patient takes, you sort of look at the laminate, oh, this is age, height, tidal volume, take a calculator out and calculate it. It's such a kerfuffle. So what we did was, on the Draeger ventilators we have, we had to input height before you start the machine. And of course, in some patients, you had to start the machine right away without measuring height, but you had to go back in and and put the height in again. And we changed the front end of it. So now, instead of me calculating tidal volume divided by weight, I get 6.1, 6.2, 6.3 mils per kg shown to me. Yeah, so I'm just making myself look into it. That was, my cognitive input was just completely taken out. And by just changing from BiPAP to SIMV and doing that, we saw a big improvement in tidal volume performance. Then we started displaying it on dashboards. So it wasn't the individual nurse's responsibility to get the tidal volumes down. It was the whole unit's responsibility. So when something turned red, everybody would know it. And somebody would go and say, Why is the patient's tidal volume at 8 ml or 9 ml? And the smartest thing I think Chris did was he shared our performance every week. And this was the very polite email. He said, as a unit, we agreed we'll aim to ventilate our patients for less than 6 ml of idle body weight for at least 80% of the time. And he would give a performance metrics every week for each consultant's week on. Anyone use Strava or Runkeeper app? Yeah, for the competitors among us. Yeah, it's sharing performance. It's instantaneous feedback. And this is the drop in tidal volumes by just changing the front end, displaying it, and sharing an email. And to simplify it further, before we did the study, 40% of our time was spent at more than 8 ml per kg. And now it is less than 1.8% of the time the patient spends more than 8 ml per kg. And we try to translate some of this into clinical practice. So this is an ARDS-NET patient, severe pneumococcal pneumonia, Klebsiella pneumonia, severe ARDS, 6 ml. We prone them on day 1, we prone them for 5 days. And we were able to extubate this patient on day 7, and we repeated a CT scan, that's the lung at day 7. So what next? So everything is around treatment of ARDS. And I just want you to think a little bit more. Can we prevent ARDS? Yeah, anyone, any ideas on how you can prevent ARDS? Back to the slide, community-acquired ARDS versus hospital-acquired. What's the commonest cause of community-acquired ARDS? Pneumococcal pneumonia. Can you prevent pneumococcal pneumonia? Vaccination. Yeah, so he's taking the intensive care outside his wall, outside his comfort zone. Is also about preventing ARDS by doing this clip mnemonic. You can have targeted tidal volumes, supervisory intubation, adequate fluids, restrictive practice, and spontaneous breathing trial. We can prevent ARDS in patients at risk of ARDS. We can also think about, there are lots of trials, and I haven't spent time going through it, but there are the new thought process around how you use small tidal volumes in the operative settings, in theaters. We also need to think about regionalizing services. Would you accept a oncologist or a surgical oncologist doing an esophagectomy in every hospital? Would we accept that? Do we have a tertiary chemotherapy center in every hospital? We regionalize it. We regionalize trauma, we regionalize cancer. Why can't we regionalize some of this stuff? Again, it's physician-induced injury. And lastly, I think we need to collaborate better. One of my aims is to have a database of all ARDS patients in the country. If you have a leukemic patient, every leukemic patient in the country goes onto a database. Every leukemic goes into a trial. Our recruitment into ARDS is abysmal. We don't have a database. I can't tell you what is the outcome for a pneumococcal in a 40-year-old in UK. So we need to have a better database, better collaboration. And we need to move away from this, again, the kind of physician paternalistic medicine that I think I'm doing right for the patient. We really need to have better follow-ups and better feedbacks from them. So to conclude, I think the first principle is you treat the underlying problem. Second is do no harm. There is the aggregated marginal gains. Let's see, can we improve every other element of intensive care around the patient? Again, changing that language about therapeutic hypercapnia, permissive hypoxia. If I was I would ask all of you to recite it, therapeutic hypercapnia, it just has to change, the language has to change. Of course, there's place for rescue therapies, but let's get our basics done right. And there is place for experimental therapies. There's a trial coming up with stem cell transplants, trial coming with interferons. But let's get our 6 ml per kg right. So how would I ventilate? I keep it really simple. low tidal volumes, reasonable amount of PEEP, permissive or therapeutic hypercapnia. It doesn't matter whether it's BiPAP or SRMV. We use SRMV. I used BiPAP before. Before that, I used SRMV. It doesn't matter, I think. Except a bit of hypoxia. The strategy that we have on our unit is early proning as a rescue therapy. And this is the kind of algorithm that we use: mild, moderate, severe. Low tidal volume underpins all that. High PEEP is towards the severe end, and everything else towards rescue. Thank you.